Welcome to the Neuroendocrine Cancer Foundation podcast. I'm your host, Lisa Yen. I'm the Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with neuroendocrine cancer. In each podcast episode, we talk to an expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician. I'm really excited to introduce our guest for today, Dr. Diane Reidy-Lagunes. Dr. Reidy is a medical oncologist who cares for gastrointestinal and endocrine cancer patients, including those with neuroendocrine cancer. She joined Memorial Sloan Kettering Cancer Center in 2008, where she served as the vice chair of medicine and held multiple other leadership roles. As a researcher, Dr. Reidy has focused on developing methods to integrate molecular-based therapies into the treatment of neuroendocrine tumors, and she is a member of the Neuroendocrine Cancer Institute Task Force on Neuroendocrine Tumors and the National Cancer Care Network Guidelines, and is a former board member of the North American Neuroendocrine Tumor Society, or NANETS, which you've heard us talk about. She has received numerous awards and honors, including recognition as one of Castle Conley's top doctors. And we're excited to share that effective April 1st, 2025, Dr. Reidy will join Duke University Department of Medicine as the chief of the Division of Medical Oncology. She will hold an appointment as the Associate Vice President for Oncology Services for Duke University Health Systems as well. And what this means is we will be having a NET expert in that area of the country, which is much needed, and we're really excited to see her going there. Congrats, Dr. Reidy, on that. What I really also wanted to share is that Dr. Reidy is the creator and host of an award-winning monthly podcast called Cancer Straight Talk from Memorial Sloan Kettering Cancer Center, which connects patients to cancer experts with the goal of having evidence-based conversations on a variety of topics in cancer care. Cancer Straight Talk is really an engaging podcast that does just what the title says. Dr. Reidy has these really honest and open, transparent conversations about a range of topics, many of which people may be afraid to ask about or too shy to talk to their doctors about. And so that's why we wanted to invite Dr. Reidy to join our podcast today to share some of her Cancer Straight Talk and the spirit of transparency, which also applies to the neuroendocrine cancer community. And we'd like to hear her insights about that. So Dr. Reidy, welcome. And if you could share a little bit about yourself and perhaps a fun fact and how you got involved in the neuroendocrine cancer community.
Thank you so much for that warm introduction, Lisa. And I am absolutely thrilled to be here. As you said, I've been a medical oncologist at MSK. I did my training here as well. So I've been here almost 20 years and super, super excited to start this new chapter at Duke in the Cancer Institute down there and as part of the Duke Health System. And so I have had a passion to care for patients with neuroendocrine and other adrenal malignancies. And that's been what I've developed here with my colleagues, Dr. Nitya Raj and now Dr. Rohit Thamalapalli. And so we've tried to develop both clinical trials, but also really trying to focus on both quality and quantity. Thank heavens our patients can live for a very long time. But I think importantly, because of that, we have to be very, very focused on the quality of life issues of what therapies we use and when, so that we use those cards carefully and appropriately. And so I'm just so grateful to be here to talk about all different aspects of cancer. And I tell my patients all the time, I take care of all of them, not just the disease itself. And so I think a lot of the topics you want to discuss here is something that are near and dear to my heart, because it does help us live longer and happier lives by thinking about these things and not just focusing on the treatment at hand.
Quality of life, and not just treatment, but really talking about everything. Thank you for that.
So my fun fact is I was actually rejected to medical school when I first applied. So for anyone out there that may be listening that wants to be a future physician or anything in healthcare and feel like they were rejected, there is always hope, because I think I'm doing pretty well right now. I actually got rejected twice. And the second time I was waitlisted at 9 schools. And so I last minute decided to take a job in Spain for the summer, thinking I would get off of a wait list. And went to Spain. I thought I spoke Spanish. The only place I could get a job, I'm not joking, was at the Hard Rock Cafe. But then I didn't get in. And so I ended up finding a job, amazingly, teaching science in an English Montessori school for junior high kids for the year. And spent the whole year in Madrid, where I learned Spanish and had Spanish-speaking roommates that were phenomenal. And then when I reapplied, I got in all 9 schools. And then I came back, and then within 4 months, I met my husband, who's Mexican, and now we have a bilingual family. So I always feel like sometimes the universe works for you, even when you think that you have all these rejections. But I always share that story with folks to say that sometimes there's a reason why the universe provides that rejection. So I'm kind of a big believer in that. And then I started at my cyanide training.
Wow, that's really an inspiring story. You're right. That speaks volumes, right? Sometimes there's roadblocks, and when a door is closed, it may end up in something better.
100%. And I think that in our society, we look at rejection as something we did wrong and that's a failure. But I do think there's opportunities there. So I like to share that fun fact, just saying, now I speak Spanish and my kids speak Spanish. And it was a hard time. I'm not saying at all that to get so many rejections at that moment, it felt like, am I not supposed to be doing this? But it all worked out.
Yeah, there's lessons we learn for all of us, for the greater community, but also even in neuroendocrine cancer, I'm sure. Patients, caregivers, I mean, we hit roadblocks and maybe that'll lead us a different direction.
I am a very big believer in that. So very well said.
Can I just also ask, what inspired you to start and host this monthly podcast, which I imagine is a lot of work on your part, and we also really appreciate?
Yeah, I think the conversations that repeatedly would come up in clinic from patients were really important. And I had a moment where I was like, do we have answers to this? And sometimes people would be like, oh, it doesn't matter. Like, for example, can you eat sugar? And so many times oncologists say, eat what you want. You have to have calories. And I really kind of paused and said, is that true? Do we and can we and should we eat what we want when we're having cancer or not? And so those kind of things were really an interest to me. I studied nutrition undergrad, and it's a passion that I had. And I knew that for certain patients, like, we do need calories because of the cancer, losing weight and other things. But that question, along with exercise and sexual health and things that I wasn't even asking about sexual health. And how could I not be asking about sexual health? And so having those conversations, I thought, if I wasn't asking them, like, who is, And so I thought those were conversations that, again, were really something that needed to be discussed more readily and had to have some evidence behind it on what we can do. And is this a problem? And so on and so forth. So there were repeated conversations in clinic that I thought, you know what? We need to get this to a broader community and answering these questions, not only for my patients here, but the patients in the cancer community. And so, believe it or not, I pitched at MSK many years ago. And at the time, the Department of Communication was like, no, that's not really something we do. And I think that they were just missing it. They weren't getting it. So I actually started just recording with my nephew, who's a pre-med, and with various colleagues of mine. And so I did like 8 episodes. I did one with Jed Walchuk on immunotherapy. I did another on a young person. I did another one on sort of the ABCs of cancer. I'm just really trying to understand what is cancer with Dr. Matt Manazar, who's a lymphoma expert. And then I had my nephew edit it. And then I gave it to him. I said, this is what I think we need to do. And they were like, we get it. And so amazingly, we did that. And then a board member from MSK happened to randomly come across it at an airport and then listen to one and listen to another and listen to another. And he really was inspired by the messaging of what we were trying to do. And so he helped support getting a producer and an editor and other things to get it off the ground. And so that's where we are, 60 episodes in. And my last one will unfortunately be coming out next month, because as I go down to do, maybe I'll do something similar, but won't be taking Cancer Straight Talk. So that'll stay under MSK, and we'll find a super special host for that.
I love that story, and congrats, because I saw that you won the prestigious 2024 Gracie Award for the Best Educational Podcast and the Grand Award.
Yeah, that was super exciting. I actually took my daughter. It was so nice. It was in LA and the Beverly Wilshire. And it was across the board for women in entertainment. And so there was Carol Burnett there, and there were just all these amazing actors, and we got the grand award. So it was like our little podcast that could. We were so proud. And I think they just were touched by the idea that we can build a podcast or a product, if you will, that really focuses on the patient and the humanistic sides of the patient too. I think so much out there is focusing on science, and sometimes is legit and sometimes not so legit. And there's a lot of people out there that make big names for themselves and having a lot of conviction and not necessarily behind the data. So we're trying our best in the cancer space to use the best available data to debunk the myths and make sure that patients are not going down a trail that is not necessarily helpful for them and could be harmful, but then also thinking about ways to empower patients to do the right things.
And a lot of patients are so afraid, as you know, to talk about these things. They might feel like their doctor is going to judge them, roll their eyes, and these questions might feel dumb or scary. And you just make it so permissible, non-judgmental. You do it in such a sensitive way if needed, or a light way sometimes if needed, with a little humor, and delve into these topics in just a really incredibly educational, but sensitive, all of it wrapped together, and just really enjoyable to listen to.
Thank you. We sort of made it as if it were a library. We recognize that sometimes people are going to want to listen, and sometimes they say that's not one that would be so much of interest to me. Like one really big one for our younger patient populations is the adult young adolescents and what it's like to have a cancer so young. And so obviously that's incredibly important because it can feel so isolated and lonely when you're young and you feel like you're the only one in the waiting room that's 20 or 30 years younger than everyone else. And so that's really important for that patient population. Then we have another one on the role of the caregiver, or how do you talk to your kids about cancer? And so you can imagine for that patient population, it can also be very, very important for them, or the role of the caregiver, and how we don't, I believe, in our healthcare society recognize enough how critically important and how hard that role is. And we don't really, with rare exception, do much at all to support them. It's sort of like, here's your patient, here's your loved one, figure it out. And it can be incredibly challenging. So recognizing that it's a problem, we may not have all the answers, but to say you're not alone, we hear you, we feel you. Here are some things that you can do to at least try to ensure that you're taking care of yourself and that you're getting the right support that you can hopefully find. I think with that sort of library approach, people really appreciate it. And some people just say, oh, I listen to all of them, which I love, obviously. The more they listen, the better I feel that we're doing something right. But I think there are a little bit of tidbits in each one that we're trying to give pearls of wisdom in every pod.
Absolutely. There are so much wisdom in them. And on behalf of caregivers, I know Heather and myself are both caregivers, and we really appreciate that attention to caregivers. There are so many pearls here. And so what we did was just select maybe 10 topics that you've touched on. And I know we won't have time to go in depth, but really just touch on them and answer a couple questions about how they might also relate to neuroendocrine cancer. So the first question, something you talked about in one of your earliest episodes, is what is cancer? And is NET a cancer? People ask this all the time.
So NET is absolutely a cancer. A cancer, by definition, are cells that have the ability to divide, or what we call proliferate, and then spread. So most neuroendocrine tumors have the ability to divide and spread. Now, there are a couple of them where the chances of them dividing and spreading is exceedingly low, like an appendix neuroendocrine or a gastric neuroendocrine type 1 or 2. So some of them don't. But by definition, cancer is that it has the ability to do that. Sometimes our tumors, they have the ability, but they just sit there, thank heavens, and patients will pass with the disease and not because of the disease. But again, it's that ability. And so why does it do that? Or how does it do that? And importantly, what exactly makes it a cancer? So by definition, what happens in a cell that eventually becomes a cancer is that the cell itself is damaged. And believe it or not, that often will take years. And so what I mean by that is the damage of the cell occurs in the genes, and we call that a mutation. And so it could be as early as in utero, something in that cell gets damaged, and so it develops a mutation in the gene. And then it sits there. And then maybe a couple of years later, another mutation develops. And then maybe 10 or 12 years later, another one. And then 20 or 30 years later. And so I use the analogy of a bingo card, that it's the accumulation of those mutations that in some patients, bingo, now you have enough mutations that now we're in trouble, that cancer cell that should have been recognized by the immune system as foreign or damaged and turned off, now can turn on and it starts to divide. And then it has the potential to start to grow. And that's why cancer typically is a disease of aging, because it takes so many years for those mutations to develop and then eventually develop the cancer. Now, sometimes there's a bigger, what we call driver mutation that doesn't need so many mutations and can be a little bit more aggressive, because so can happen a little bit earlier. Or sometimes it's what we call a germline, a mutation that was passed down from mom and dad that can make that whole process happen earlier. But for the vast majority of cancers, it's that accumulation of mutations over time that eventually lead to that cancer developing.
Thank you for that really thorough explanation. I think what's so confusing is with neuroendocrine tumor, it doesn't have cancer in the name. So how is this a cancer?
Yeah, and it's what's in a name. It goes back even to that carcinoid, which meant cancer-like in German 200 years ago. And the problem is when the pathologist used to do autopsies and it would found that cancer in these patients, and he would say, they died from something else, so it can't be a cancer, but they were dying at 40 from tuberculosis, and he figured that out later on that it is a cancer. Just in most patients, thankfully, it can be a slower growing cancer. So patients can live, thankfully, for many years and hopefully many decades, depending on the type that they have. But then many patients can succumb to the disease quite quickly. We do not do a good job in defining neuroendocrine tumors, neuroendocrine carcinomas. I personally think we need to rename all of it because there's just so much confusion there. But in fact, it is.
What would you rename it if you could?
I think it's a neuroendocrine cancer. And then I think we can characterize the different types of neuroendocrine cancers that we have. And then I think what we call neuroendocrine carcinomas, which are much more aggressive cancers, should probably have a completely different name, like a poorly differentiated carcinoma or something completely different, because patients can get so confused about what type of treatments that they need based on the neuroendocrine part and what's their outcome and their prognosis. And so there's just a lot of, I think, unnecessary confusion sometimes that our patients have to endure.
So for the purposes of this podcast and our community in general, we're using these terms almost interchangeably, like neuroendocrine tumor, NET, neuroendocrine cancer. So we may be referring to them and it gets a little confusing, but it is the same thing and it is all cancer. So the next question I have is really the number one question we get from the community. And it's interesting to hear that your background is in nutrition. So I'm sure you get this question a lot as well. The question that most people ask is, should I follow a certain diet? As you talked about these drivers of cancer, people worry about that. And the number one question we always get is, does sugar feed cancer?
So the podcast that we have that is on does sugar feed cancer has something over like 50,000 downloads, close to 60, I think now. It's a really important question. And I think what I learned from Dr. Santosh, who was my guest on that call, is that it's probably not great for any of us, whether we have cancer or not, to eat pure sugar. It's just not good. And that a plant-based diet has been shown time again to be a better outcome for all. But cancer will feed off of anything. So the original data on cancer and sugar comes from test tubes, where if you give a cancer cell sugar, it takes off. But if you give a cancer cell fat, it takes off. If you give it protein, it takes off. If you give a cancer cell, it takes off. It actually will eat another cancer cell. So cancer eats whatever it can get its hands on. So I think that is important. But there are people like Dr. Neil Iyengar, which is another podcast that we have, that have actually dedicated their careers to defining different diets for patients with cancer, undergoing treatment or not undergoing treatment, or decreasing the risk of recurrence. And time again, it shows that a well-balanced diet is probably just good for all of us. And that the data do show that if you can eat better fruits and vegetables, less meat, less saturated fats, and definitely less processed foods, that the outcome is probably better. Now, there's a lot of what we call selection bias in there, but it's okay. It's good, healthy living. And the same thing goes for exercise, which I'm a huge advocate for. It does show that those are good things. Now, having said that, as I sort of alluded to before, some of our patients have a really hard time keeping weight on because they may have a neuroendocrine carcinoma or the cancer is picking up its pace. And when the cancer is growing, it's literally taking away our energy. And so it is trying to take that energy, and sometimes it's from our own muscle if we're not eating well, or our own fat, or our own glucose, etc. So we have to be very mindful and careful that we need calories. And so shakes and sometimes simple sugars, we don't necessarily want patients eating Skittles, but it is really important for certain patient populations to get the calories that they need. But I think in general, if patients can tolerate a well-balanced diet like that, the data suggests that it wins out and our patients have better quality as well as quantity in that respect.
So maybe not just binging on Skittles all the time and then just weighing what is the priority.
Yes, I think that's absolutely right. Now, some of our patients may be listening and saying, because of my disease, I go to the bathroom 6 or 7 or 8 times a day. How am I going to eat vegetables? And so there's nuances and there's exceptions to the rule there. But eating fiber that is soluble, that maybe can help absorb some of that stuff, if your body can do that, like beans and other things that may be good for us, is also a really good approach to try. And then just being mindful, if patients have histories of blockages, sometimes vegetables are a little bit tricky. But I think the idea is just trying to stay away from processed foods, and simple sugars is probably a good thing.
Okay. So it really depends on one's needs.
Yeah.
Okay. Thanks for that clarity and explanation. So you alluded to exercise. This is something that comes up a lot. Can I exercise if I have metastatic neuroendocrine cancer? I think there have been people who find out that their liver is full of tumors and they might have been very active and they don't want to maybe dislodge the tumors or do something that might hurt them and stop exercising. So there's concerns, especially about more rigorous exercise.
So Dr. Lee Jones came on twice to our podcast to talk about this. He's another investigator here at MSK who's dedicated his career with a focus on trying to conduct trials with exercise in patients that have had cancer to try to decrease the risk of recurrence or have active cancer to try to see if it can help them either have chemotherapy work better or their treatments work better or before surgery to have a better outcome and or improve the symptoms or mitigate some of the symptoms. Really powerful data. I mean, exercise is critical. The problem is what kind. And so that's a lot of the work that he does in sort of saying like, how much aerobic, how much anaerobic? What do we really need? What is the best type? And he believes that there's going to be a prescription for different types of cancer and maybe even based on our own genetics, which is just fascinating if you could sort of define the right exercise. But we're not there yet. I think a good basic, I would say, rule to think about when you're interested in maybe exercising is actually taking your resting pulse and then taking that pulse again on the day that you want to exercise to see, is this a good day? Because if your pulse is up, because again, a lot of our patients may have clinical symptoms and reasons why they may not be up for exercising. We don't want to push ourselves when we're not feeling well. But for the person that has a normal pulse and they're feeling it and they take their pulse and it's good, please, 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 I encourage you to exercise. Even if you have disease in your liver, that is absolutely okay. You know, if anything, it probably can strengthen our immune system and help us ensure that we're doing everything that we can to help fight that cancer. So I am a big believer in exercise in patients with metastatic disease. And Dr. Jones's data really suggests that that's a good thing to do. That people that exercise more regularly, at least 3 times a week of some sort of aerobic activity, tend to do better. And so I think even in the setting of metastatic disease, now, if your heart rate is up, you're not feeling well, it's sort of one of those common sense things like, please don't try to push yourself.
Yeah, so exercise is good. And then what about people who have neuroendocrine cancer, may be extremely active? So what about people who are into weightlifting, mountain biking, snowboarding, rock climbing? There's all sorts of extreme sports.
I mean, keep on going. If that's something that your body is accustomed to and you want to do it, you should absolutely do it. If you've never run before and you're like, I have cancer, so I want to exercise and run a marathon. I mean, I do have patients with stage 4 disease, neuroendocrine, that run marathons. In fact, I have more than one. But they've done it before and they've gotten themselves to a place where they can do that successfully and feel well and be able to do that. But I think there is no limitations on exercise when you're feeling well. It's just you don't want to push yourself when you're not feeling well because that's when we can get sick.
Okay, a balance. Maybe not the time to take up an extreme sport. Keep doing what gives you joy. So, I really do want to also touch on some of these sensitive topics that you did such a beautiful job with in your podcast and really in the realm of relationships. So oftentimes people, you'd mentioned the young adults, they're single or dating or engaged. I want to introduce this topic of what does neuroendocrine cancer mean for my romantic life? How might it affect dating?
So this is a really good question. And I think we could probably talk about an hour on some of the challenges of living with neuroendocrine disease, particularly, I guess I'm thinking about in the stage 4 setting. I think for those that have had resections and have been free of disease, hopefully sometimes you can get surgical issues that can cause some quality of life problems. But I think for the purposes of this conversation, it may be more helpful to focus on our patients that have stage 4 disease that may or may not be on active treatment. And I think one of the silver linings with our disease is many of our patients can live for many, many years, if not decades, thank heavens. But it can get tiring. And I've heard very, very sadly, a couple of my patients feel like it's lonely, even when they have a lot of support, but it's like people just expect like, get better or don't, but enough kind of thing. Almost as if people forget that they have cancer because they're living so long and look how well they look without a sensitivity of, it is so hard to have this cancer every single day. And it's still a cancer that you have to wake up and realize that you have every single day. And I think sometimes because of that, you're not going to feel as romantic as other folks. And sometimes you will. And so I think the key there is to give yourself a break. And hopefully your life partner or whomever you are having sexual plans with at that time can be sensitive to that. I do think, though, that just because you have cancer doesn't mean you can't be romantic. And if you're not feeling it, but you want to feel it, there are absolutely a lot of different types of interventions to help that. So it may mean, for example, for a woman that you have a lot of dryness and you don't feel like being sexually intimate with somebody because of that. There are a lot of ways to fix that. It may be that your drive is a little bit down, and there are very good folks out there that focus on sexual health. And so I think both for men and women, men may feel, I may not be able to, for example, have an erection, or I may not be able to feel like I'm intimately excited right now. And that may be for a couple of reasons. So if you're interested in saying, well, why is that? Is that normal? The answer is no. And you should seek out an opinion on what might be helpful for you so that you can be intimate if you choose and that you can have a romantic situation and romantic life. So I think importantly, sometimes whether it's the chemo or even the cancer itself, it can affect the romantic part of our lives. And I guess the big take-home message on that is that there is help out there if you're so inclined to go out and seek help and get the right interventions to help you and your loved one or your partner do what you want to do. I mean, that's a major part of being human. And yet, how many of us have really had that conversation with our docs? It's insane. We just don't. It's like society is like a taboo thing, but it shouldn't be. And so I think that's what's really important to emphasize, that it's okay to say, I'm just not into it. But then maybe if you say, I'm not into it, but maybe I want to be more into it, that you get the help that you need. And so we have on the podcast a couple of ideas on how one might do that in terms of different interventions.
It's amazing that you talk about so openly in a couple of these podcast episodes. And that was specifically where we were going next. So I'm wondering specifically with neuroendocrine cancer, how it might tie in or affect sexual health, if at all. I mean, is there anything about neuroendocrine cancer specifically?
Well, I think that all cancers can affect sexual health, sometimes based on the surgery that we're doing, depending on the location of the tumor, and that can affect the reproductive organs. Sometimes even the cancer itself can affect the libido in a way that we don't appreciate. And we do have data for that for different types of cancers, not specifically to neuroendocrine, but extrapolating from other cancers. We definitely know that. And then, yes, sometimes the treatments absolutely can affect the sexual drive, and also we'll maybe get to fertility as well. But I think these are important conversations to just take a step back and be like, how am I doing in that realm, if you will? Like, are we doing what we want to be doing, and are we comfortable? And are there ways that maybe we can improve the situation?
So if I was someone who wanted to talk to my doctor or get some help, who do I ask, or what kind of person am I looking for?
Some cancer centers have sexual health clinics, both for men and for women, and they're usually different folks. Not surprisingly, we have different reasons biologically for that. Sort of men's sexual health tends to be done by urologists, and GYN and fertility specialists sometimes can help with the sexual health for women. But I think that starting with your oncologist could be incredibly helpful, just to ask if they have that. And if not, typical GYN basic folks and or urologists can also help on that, because I don't think there's something specific per se. There's different reasons why sexual health could be altered or affected, I would say, whether it's the treatments or the disease or other things. So hopefully there would be a sexual health place in the facility where folks are getting treated. But if not, I think just general GYN or urologists could at least be also a start. If you're in the community and you're really not sure where to go, just share some of that, because a lot of the interventions are similar to folks that don't have cancer but have similar problems.
Yeah, and thank you for naming it. I think people are afraid to talk about it, to say, hey, I'm experiencing decrease in libido or dryness, and make it less taboo.
Yeah.
And so there are interventions.
100% there are interventions. And thankfully in our disease, unlike other diseases like breast and ovarian cancer, our cancers are not driven by estrogen. So sometimes the estrogen patch or estrogen suppositories, they can be incredibly helpful for folks. And it is exceedingly unlikely that it would drive the cancer to grow or anything like that.
What about for men?
Yeah, same thing. Men may have decreased libido, decreased ability to have an erection. And I think that these are really common things that many men have, but particularly with our disease and particularly with the treatments associated with neuroendocrine cancers, it can sometimes affect that. So I think it's something that's very important to at least ask yourself how you're doing in that category. And if you think something's changed, to either speak to your oncologist or maybe your general practitioner, like somebody that you're comfortable with. But I think once you get past that first step, all of us get a little embarrassed that we didn't ask. And so having the courage to at least bring up the conversation if it's not being brought up already, I think is critically helpful.
I love that take-home message, really having that courage to talk about it and open up that conversation. So you alluded to the next topic, which is fertility and family planning. So what does neuroendocrine cancer mean for fertility and family planning? And can I have children?
So this is a really important topic. And in fact, with Dr. Emily Bergslin, I have put together a group of folks to answer this question for neuroendocrine, particularly in those with a stage 4 setting, because we have had patients that have gone on, both men and women, to have family planning and have children. And there's different ways to do that. And the NCCN guidelines have some guidelines on fertility and family planning for patients with cancer, but not with neuroendocrine. And I think this one is really important because, for example, if you're on octreotide or lanreotide, there's not great data on safety of any medications during pregnancy. But the anecdotal reports that we have seem to say that it's safe, but again, very, very small numbers, so hard to say there. But I think it does go back to the very beginning of our conversation, which is how do we take care of the whole patient? And family planning and fertility is so critically important. And so if you're young and have the ability to start a family, either a man or a woman, and have stage 4 disease, what can we do to at least have the conversations to say, can you and should you have a child? The decision on, is that something that I do or don't want to do, has to fall on the patient. But who are we to judge and say, no, you can, or yes, you can? Incredibly important, though, is anytime anyone is about to start a treatment that are thinking about maybe having a baby in the future, sperm banking and or having a discussion on either egg and or sperm preservation is incredibly important, because one treatment sometimes can completely affect the ability to do egg preservation or sperm preservation. So you really want to have that conversation early on, like, okay, I know I'm about to start this treatment. Should I get some sperm preservation or should I do egg preservation? Because there are treatments that can definitely affect it. And even the cancer itself can affect sometimes the ability to collect the sperm or to collect the eggs. But importantly, there's a lot of different ways we can do it to at least have it so that in the future you can make important decisions. So for example, a very common drug that we use in pancreatic neuroendocrine tumors is the oral pill temozolomide, which is not so good for eggs or sperm. And so that is one therapy that I would say, please, before doing that, let's have a conversation with the specialists in fertility to say, what can I do? Because it's not difficult to do sperm banking and it can be expensive. And we actually talk about that on the podcast in terms of costs and ways to mitigate that problem. But even the egg preservation, it's not fun with some of the injections, but it can be done quite quickly. And so people always worry about, well, I need to start treatment right away. And that's a conversation to have. But believe it or not, the vast majority of my young folks that need treatment, I can get them to get their preservation and safely doing it in a way that's a win-win for everyone.
Wow, that is such an important topic. And you named so many little tidbits here. It seems more and more common that we have people who are diagnosed early in their 30s and need to think about this.
That's exactly right. And they should think about it. I think that's a really important take-home message, that people think that, okay, then now I can never have kids and now my whole life has changed. That may not necessarily be the case, depending on the type of cancer that they have. There are resources to at least ask the question, can I and what can I do to potentially prepare for that?
Thank you for that. That is really, really helpful. And if people want to learn more.
So we do have a podcast on fertility that just came out last month that we're very proud of. And there's a bunch of resources online on fertility, different places to go that would hopefully be in our listeners' communities. And then really starting with your oncologist. Almost every cancer center should absolutely have nurse practitioners that can help direct patients to fertility preservation.
Thank you. So Cancer Street Talk, episode 59, and then talking to your facility.
Perfect.
So speaking of families, many people already have kids. And this question comes up, how do I talk to my kids about cancer?
Yeah, this one's so hard. There's a couple of things we've learned with many years of research in this space that, not surprisingly, kids are so much smarter than we think. And every family is different, and I would never judge a family on what they decide ultimately is best for their family. So I think that's critically important. But in general, the more transparent we can be for kids with different conversations at different levels based on their age can be incredibly helpful. So obviously you're not going to have the same conversation with a 3-year-old or a 5-year-old as you would to a teenager or a young adult. But I think that particularly the teenage years and beyond, we have found that, believe it or not, it can be incredibly helpful for those kids to be able to have the transparency so that they can ask the right questions. Depending on the age of the kid, for example, we found that some kids feel like maybe they think it's contagious, which is obviously not the case. Maybe they think they did it, which is obviously not the case. There's so many misunderstandings and misperceptions sometimes. And so I think our job as parents, and I always consider that my most important job, is to protect our children, right? And so many of our patients feel like I'm not telling my kids because I want to protect them, but the reality may not be that. So I think really, really importantly to speak to the social workers that have dedicated their careers into teaching patients and loved ones how to have these conversations. There's support groups out there, psychologists and psychiatrists that can guide that family into having those conversations and when the right time is. I think one of the things that's really important is making sure that the kids know that there's a plan. I think all of us need a plan. One of the hardest things about cancer is get me a plan so that I know that I am in the right direction. And the kids want to know the plan too. Trying to get as much data as you can beforehand can be critically important. And then trying as best as you can to be as honest as possible. So like not saying mommy's absolutely going to be okay. Well, we don't know if mommy's going to be absolutely okay. But instead saying, mommy is here for any questions you have. I love you. I'm going to be here to answer all those questions. And we're going to see what the doctors tell us and what's going on. And I will certainly let you know. Sort of being careful in the words we use, again, because we want so badly to just protect our kids. But we don't want to say something that may be not necessarily true. And then there's confusion there. So the more transparent and honest we can be, I think the better off for everyone. And also as parents, we would bear the brunt of anything for our children, but sometimes that enormity of the stress of not being as honest and open as we want could take a toll on everybody, and then on the caregiver or the loved one or the partner. And so it gets a little bit complicated how much we're saying and why. And so I think first and foremost, having a conversation with the social worker or psychologist on, for my family, this is the concern based on my children's age and situation. How can I best address this? That's going to be the healthiest for everybody.
So using those resources, and oftentimes we forget there's social workers even at the facility and psychologists. That can help.
Exactly. And they really can help guide us. And I think nobody should feel like they're going to do it alone. And it's just one of those things that as an oncologist, I'm so focused on the treatment in front of me, but then we forget to say, how old are your kids? You know, we got 15 minutes and we're going through all those different things. And that's another one. It just gets lost. And cancer is a family disease. And we have to recognize that to make sure that we're all accounted for, if you will, in terms of how's everybody doing and what does that mean? And so I think it could just be incredibly helpful to have those conversations as early as possible with the psychologist or the social worker to say, this is where I am. I'm not sure exactly how I'm going to do this, but would love some guidance from you. And then you as a family decide what's the best thing.
Yeah, I hear that with honesty and clarity and really bringing them into the conversation rather than isolating anyone.
I think that's ideal. Again, recognizing that there's an age sort of requirement here, trying to teach a very young toddler something versus older kids. It's just a very, very different conversation. And maybe you are withholding some stuff for the little ones.
Yeah, so tailoring it. And speaking of plans, I know you were alluding to the plan in terms of telling your kids what the plan is for treatment, but on the other end of the spectrum, how would I know when it's time for end-of-life discussions and end-of-life planning?
So this is the hardest part of the job, right? And all of my colleagues and staff around here, we go into this space trying to cure patients and trying to keep them with us for as long as possible and as well as possible. And when we're approaching this end of life discussions, it can get incredibly hard for everybody. And I think on a society level, but also the medical community can do so much better in having these conversations. In fact, we started something here at MSK called Death Over Dinner, which was actually created by one of our PFAC members, an amazing soul. And the idea is that all of us should sit around a table, have a nice dinner, and share what's important to us towards the end of our life and what would an ideal death look like, so that there isn't so much taboo and fear around the conversation when it happens, because we just don't do a good job about it. There's just so much fear in our society about passing over to the other side. And then when patients get sick, and then we get nervous to share where we think they are. Yes, it's true that the crystal ball can sometimes be broken, and it often always is broken, but we kind of know when we know, right? And I think ideally having conversations earlier when a patient gets diagnosed would be incredibly helpful. The problem is that we want to be positive. We want to be hopeful. And so if you ask those questions, it's as if you're saying, uh-oh, something's going to happen, right? It's human nature to be like, why are you talking about that now? I'm hoping to live for the next 30 years. And the idea is like, yeah, so are we. But if we only knew what would be important to you, then it wouldn't be as challenging. Because what can happen is we sort of, and I hate the analogies, but it's just sort of the way that we are. You know, we're fighting against the cancer and providing all this hope and doing really well. And often with our disease, as we are approaching it, we're not sure, but we kind of know that we're in a different place. And then patients are so scared and they're feeling so terribly. And now I'm talking about what's important to you at the end of life. And you're like, what? I just want to get this pain away. So it's very complicated. And I don't think that we do a good job on any of this. But I would say the earlier all of us could talk about what would be important to us towards the end of life, the better off we'll be. I, for example, try to share with my patients, especially with neuroendocrine, where the overall survival can be so long. I will tell patients that I don't know for any one patient in front of me truly how long they're going to live. Is it possible for them to live decades? Absolutely. It's possible depending on the disease. Is it probable? Well, I need to learn more about their disease. And the way I do that, unfortunately, is with the test of time. How long does it stay controlled on the first line therapies? Because I have other therapies, but at the first line therapy, it quickly grows. That's a different biology. And so the more we can have conversations on what else do we have left and how are we doing? And are we still talking many years or has it changed? Again, not every oncologist is going to know and they could be totally wrong. But the more transparent we are about those conversations earlier on, the more understanding we can all have so that we're not all of a sudden in the setting of being in the end of life saying, okay, we're at the end of life here. And maybe you wanted to take a trip that you never took, or maybe you wanted to retire 2 years ago and you didn't because you were waiting for some bonus and now we're not where we want to be. Or maybe you want to write letters to people and they want to write letters to you. And so there's so much that we could do and should do when patients approach end of life. But the problem is we're also terrified and it can often happen quickly. And it can all of a sudden, like sometimes our disease can transform and it can start to act in a way that it had never acted before. Now, it's not common, but it can happen. And so how do we prepare as best as we can? So I think the key there is to have what we call here in MSK values discussions throughout the journey. What are your values today? What's important to you? What's important to your family? How do we make sure that that happens every single day to get to where we want to be and that we're doing what we need to do and are recognizing that for all of us, life is so short and fragile, but particularly for a patient with an incurable disease, can we have very honest conversations that may change over time? We may figure out today, there's no way I want to do anything. And then you get towards another place and you're like, put me on a clinical trial. That's okay. I think all of us are allowed to change our mind about things. But what we deserve is to have more than one conversation and not all of a sudden have somebody say, it's time, you need to go into hospice. And then you sort of get caught with an unexpected prognosis that you just hadn't really thought about.
Wow, you said so many important things, and I really appreciated how you explained from your standpoint how there is uncertainty and that test of time is so important. It can be hard to understand from the patient standpoint because, we don't want to wait the time. We want the answers now. And so really living in the present and demystifying those hard things, those scary conversations. I love the death dinner idea where you kind of make it normal to talk about.
That's exactly right. Normalizing the conversations. We've done it in Spanish and in English, and they are so powerful. You're sharing stories of loved ones who have passed away, which has made an impact on you because so many of our patients I've found have different interpretations of hospice or end of life things because of their own experiences. So I think understanding the narrative around how people think about end of life based on what they've had before and whether that's true or not true and could be different for that patient or for others. Again, the more conversation you can have about it, the more you can normalize it.
I know that there's like death cafes, so that similar idea.
Very similar idea.
Wow, it's like a support group for death.
A little bit. I mean, I'm also a big believer that we're just going to the room next door. I think there's just so much we don't know about it. And so I think that people get so understandably sad about it because you don't want to leave your loved ones and you want to make sure they're protected and that they're cared for and all that kind of stuff. And then ironically, because of all those fears and concerns and sadness, we don't talk about it. And then we may not be leaving them in a place that's ideal. So I think as hard as it is, having those conversations earlier rather than later can be very helpful. And hopefully it's there in a book in case you need it. And maybe you never need it for another 30 years. But just having it, I think, could be very, very helpful for all.
Yeah, I also really love the values discussion, how important that is. And in the midst of talking and thinking about treatments, to really focus on that. I know my husband and I sit down and talk about this from the very beginning, and it's what guides the treatment decisions.
Yes, I think that's right.
Thank you. So a really common question is around cannabis, especially, look, I live in California, it's legal. So should I consider cannabis?
Yeah, and I live in New York, it's legal. So cannabis is complicated. It's a drug. So every drug, you have to ask why. Why are we doing this? One of the most common questions I get from my patients is, does cannabis treat cancer? And I sort of half jokingly say, I wish if I could prescribe cannabis for my patients to treat their cancer, the world would be a lot more fun. It does not treat cancer. Really, there's no data whatsoever that suggests that cannabis treats cancer. And if anything, there's a recent study that came out that showed in patients on immunotherapy, the addition of cannabis actually halted the immune response and actually had an adverse event outcome. So it may lower our immune system. Cannabis can be incredibly helpful, though, for insomnia, nausea, symptoms related to cancer. And so the other struggle with cannabis is because we've made it a drug for historical reasons, a taboo, we never really studied it in the way that we've studied other medications, which is sort of ironic because it's the one that's not really addicting, at least in the doses that we know of. And yet we really don't know a lot about its properties. But I think I'm a little bit worried now that the concentration of cannabis is going up and that we really haven't studied that concentration of things in dispensaries and other things. Most people do low doses. If people are taking one drop to go to sleep, that's not what I'm talking about. But I think more and more people are getting more and more, that's capitalism in America. People just find ways to make it even higher and more expensive and then potentially troublesome. And I think we've certainly seen that in different patient populations, particularly our younger ones, which is worrisome. So I think cannabis for symptom control in small amounts can actually be very helpful for our patients. Unlikely to be harmful, but again, that one study with immunotherapies lowering or blunting that response is something to just keep in the back of our minds. Maybe it's not the perfect drug for everybody, but if you don't have symptoms, like everything, I'd rather not anybody. It's just like alcohol, it's not great for us. Even a glass or two, we found now, just isn't as good as we expected it to be. In fact, no alcohol is better than anything, and no cannabis would be better too. But if you have symptoms of insomnia or nausea or even mild pain, it could be helpful.
So if I'm someone who has symptoms and I'm wondering about this, is there a provider I can talk to?
That's a really great question. I think that traditional Western medicine, we really have not been trained in cannabis. And so people go to dispensaries and then there's a lot of conviction there on whether they're really trained on it and when they know about the doses that they're giving and why, I'm not sure. I mean, maybe some places are very well experienced and trained. Many supportive care services or palliative care services do have somebody that's dispensing the cannabis. I do expect to have more studies. It's just that we're not there yet on knowing what are these drugs truly good for and at what doses.
Yeah. Okay. And thanks for naming that. Palliative care, supportive medicine, these are specialties that can help guide this. So we'll end with this last question. We've had this amazing conversation, and I think we could keep talking for hours. But what I really appreciate most is your honesty and transparency and really having this open conversation with you and open communication. And I think a lot of patients would say, I wish I had this open communication with my doctor. So what advice would you have about improving conversation with my doctor?
I think that all of us get into these crazy clinics and what ends up happening in modern healthcare, and I'm to blame. So for my patients out there, I'm sorry if sometimes this may happen to you too, but I may have a really sick patient at 9 o'clock that needs me. So by 9:30, I'm running late. And so now I go into a patient who's feeling well and doesn't have anything to say, and they're doing great and their scans are great. And they say, okay, and I give them a big hug and I examine them, and then they leave. And we never had all of the important conversations like we just had today. So I think the communication is so critical so that the doc knows that these are issues, because it's not something that we're typically going to ask. We should, and I should, but because life gets in the way and there's other things that are going on in any one clinic day, often they can just get passed to the sidelines, and that's unfortunate. So I try to spend a moment in patients that are feeling well to ask anything going on, how's life, how's the family, that kind of thing, to see if there's any issues about these things. But I personally am a huge advocate for sexual health, and I don't ask all of my patients every time. So I think having conversations, but importantly, just having one or two questions or more, if you have them written down before you go into that visit, to say, these are two things I really want to ask. And then that's also sort of like, you're going to have the courage to put it up. If it's something about sexual health that you really want to talk about, put it down so that you can ask your doc those one or two questions or more if you need them. But I think the way that we're set up, sometimes we just don't have the ability to go through all of these really important questions that we went through today. So I think one or two of them for each visit could be incredibly important. And then I think you'd be surprised on what your doc will say or your APP if you're seeing someone in APP, because I think these are incredibly important. Always remembering too that people go into medicine for all the right reasons. They do want to take care of all of you, not just the cancer. And so you may feel like, oh, my doc doesn't care because they're only focused on the treatment or the side effects of treatment. That's only because those are the life-threatening ones that make us the most nervous. But doesn't mean we don't care about your sexual health or about your fertility or about your role as a caregiver for somebody else. It just means that we're trying to triage. That's medicine 101, is we're just triaging the hard stuff. But all those things matter too. So I think having that conversation and you bringing it up if your doc is really, really helpful.
Yeah, it's a two-way street. So you mentioned the values discussion. So our role as the patient caregiver, writing down what matters most to me today, the two things that I want to talk about, and making that a priority in the discussion. Thank you so much. This has been an amazing conversation. You are such an inspiration in all the work you do.
Love what you do for our community. I'm very, very grateful. And our patients are very grateful to you as well.
Oh, thank you. I mean, really so grateful for opening up these conversations, for making it less taboo, for naming it, giving it language, bringing the skeletons out of the closet and just starting the conversation. And really appreciate your work and look forward to continuing to cheer you on while you're at Duke.
Thank you.
Thank you so much. Thank you again for everything you do, and really appreciate you.
To you as well.
Thanks for listening to the Neuroendocrine Cancer Foundation podcast. We want to thank our podcast supporters, Novartis, Ipsen, Exelixis, Curium, Tercera, ITM, Resolute, InterScience Institute, and Boehringer Ingelheim. For more information about neuroendocrine cancer, go to ncf.net. We depend on donations to bring you programs such as this podcast. Please consider making a donation at ncf.net/donate.